Now, what are the other systems that may be involved? Other systems that may be involved. Now, the first thing that you have read is cardiovascular. Okay, that's the cardiovascular system that is involved. Now, next system that is the major system that was involved. Now the next small few lines are there. Now we'll end this video and we'll go for the next. Okay, in the next video we will discuss the incomplete KD and other stuffs. The central nervous system, we have already said extreme irritability. We have seen it, extreme irritability. You can see also in the word there is there are children who are admitted and who presents as extreme irritability, which subside in the subacute phase. Subside in subacute phase. And also aseptic meningitis may be seen. What we have already said, that aseptic meningitis may be seen. And headache may be there. If you do CSF, maybe pleocytosis. Pleocytosis you may see, means increase in the cells. Okay. Now musculoskeletal, we have already said that musculoskeletal, it also involved the musculoskeletal system, or it can cause arthritis, which occurs around second week. Arthritis. Okay. Maybe oligo, maybe poly. Oligo means less than equals to 4 or more than 4. If it is there, then it is poly. Okay. Now polyarticular, the most commonly affected joints are knee, more than ankle, more than wrist. Okay. Occurs in second to third week. Okay. And response to aspirin, always response to aspirin or IVIG, whatever you give. Okay. Now respiratory system and GI system, small thing. Respiratory system, we have already said it may be preceded by some respiratory infection. Respiratory system, sorry. Okay. Cough, coryza, rhinorrhea, that may be there. Coryza may be there. And maybe sometimes maybe otitis media. Okay, otitis media, plus minus sensory neural hearing loss may be there. Okay, now lastly GI system. Some GI system involvement may be there. We have already know, but just I'm mentioning here again. Abdominal pain is very common. Very common. Abdominal pain is very common in case of Kawasaki. So you should look for that. Yeah, diarrhea, in 1/4 of the cases diarrhea is common. Vomiting may be there, and sometimes you can USG can reveal hydrops of gallbladder. Hydrops of gallbladder may be revealed at and may help in the diagnosis in case of incomplete KD. And it occurs in the acute febrile phase. Acute phase. Okay. Now that is the GI system. Okay. Now I will go for genitourinary system. Genitourinary, if any involvement, yes, there are. Genitourinary system. What are the involvement that you can? Uncommon. Yes, uncommon. First of all, uncommon. Next you can see testicular pain and swelling may be seen. Testicular pain and swelling. Okay. Testicular, due to testicular inflammation, you can see. And the last thing you should look for is a sterile pyuria. Sterile pyuria. Pyuria means there will be increase in the WBCs in the urine, but no organisms can be isolated. Okay. And it is urethral origin. Always remember, it is urethral origin. So if you catheterize sample, no use. If catheterized sample is there, you cannot get sterile pyuria. Sterile pyuria is urethral origin, so you should take you should you should not never catheterize the patient and see the sample. You should take the normally voided urine. Okay, voided urine you should take. Okay, at least you can get 10 WBC per high power field, then it is called sterile pyuria. Okay, in 60% cases it may be you may get that. Okay, and last, some unusual findings or special finding, you can say, you can get that reactivation of the BCG scar. We have already said that. Okay, reactivation of BCG scar, you can see. Okay, now what are the lab changes? We'll read latter half. Now first we'll just recap and end this video. Okay, so yes, that is also covered. Now in the next video we'll go for incomplete KD, diagnosis of incomplete KD, some lab criteria and lab investigations also. That we will see what are the things that you can get. Okay, so what I've read, we have read the definitions of the KD. Again we are repeating and I will end this video. Okay, so it is a vasculitis, is a medium sized artery will be involved, coronary, axillary, iliac, popliteal. This will be involved. Unknown etiology, acute febrile illness, mostly affecting less than 5 years of age. Tomisako Kawasaki was the pioneer of this. Less than 5-year-old is the most commonly affected group. Usually mean age is 3.5 years. Japan 6 to 11 months, the mean age is 6 to 11 months. Incidence is increasing in the eastern world, but in western world it is decreasing. Siblings of the KD has high risk of contracting the disease. Second and third attacks can be seen in 1.5 to 3% of the cases, and some seasonal variation has been seen in the Japan and Taiwan. Pathogenesis, nobody knows, we already mentioned that. Pathology, we said that first phase there is a saccular aneurysm that is converted into fusiform aneurysm. In acute phase there is a neutrophilic necrotizing arteritis, primarily involve the endothelium, and lastly there is fusiform, lymphocyte, plasma cell, and eosinophil will involve. Later on fibrosis and stenosis. Criteria complete. We have not read the incomplete. We will read it in the next video. So complete 25% cases, if it is untreated KD, will form coronary artery aneurysm. So we must diagnose it. There is no definitive test for diagnosis. No definitive test. No definitive tests. Okay. Hence the criteria is so important. Leading cause of acquired heart disease is KD. Most children who never meet the criteria are more prone to develop coronary heart disease. We already know youngest patient will not develop all the spectrum of KD. Unfortunately, they are more prone to develop the coronary artery aneurysm. And any children more than 7 days, always screen for echo. So mean duration, what is the essential criteria? This is the criteria. Okay, so criteria, what is the essential criteria? That is fever. Essential criteria is fever for 5 days or more. Mean duration is 12 days. Okay, and 4 days if there is omission of fever after IVIG. Any 4 of the 5 signs and symptoms: bilateral conjunctivitis, oropharyngeal mucous membrane, lips, tongues, the changes in there. We have already said changes in the peripheral extremities, polymorphous rash, non-vesicular rash, mostly involved in the trunk, cervical lymphadenopathy. Disease course, we have already said the acute, subacute, and convalescent part. And lastly, cardiovascular system, we have already said it, but you should always remember what is the echo criteria, what is the Japanese Ministry of Health criteria, American Heart Association criteria, and if there are suggestive features, at least 3 suggestive features, you can stamp it as echo positive for Kawasaki. And when to do echo? Just at the diagnosis, after 1 to 2 weeks of illness. If it is normal, then repeat at 6 to 8 weeks. If it is abnormal, much frequent echo. Central nervous system may be involved. Affective meningitis may be there, headache may be there, CSF cells may be higher. Musculoskeletal, we have already said. In the 2nd to 3rd week, response to aspirin or IVIG. Respiratory system, specific finding is otitis media, which you can get. GI system, abdominal pain is very common. Hydrops of GBU in acute phase can be seen. Genitourinary, the sterile pyuria, urethral origin, always remember that is an urethral origin. Catheterized sample, no use. Should take normally voided urine more than 10 WBC per hyperfield, and reactivation of the BCG scar. What I have already read is definition, epidemiology, pathogenesis, pathology, and criteria for complete KD. I have also read the disease spectrum of Kawasaki, which is divided into acute, subacute, and convalescent phase, and also seen the different system involvement by Kawasaki. Now next we will be going for lab investigation and what is atypical KD and incomplete KD, and diagnosis for that, and echo and treatment. So these things will be reading in today's lecture. Okay. Now the next part that I am going to is lab investigation that we can get. Okay, the laboratory investigation. What we can expect in KD. The first thing that you must expect, the first thing, that is elevated ESR and CRP, because they are a acute phase reactant. ESR and CRP will be raised. If ESR and CRP is normal, if normal, it's not KD. It's not KD. Okay, so if it is normal, it's not KD. So that's the first thing. Raised ESR and CRP, that's universally present. Okay, that should be present universally present. Okay, keep that in mind, that is universally present. Next thing, the first is this. Next thing, CBC, complete blood count or complete hemogram, whatever you say it. For hemoglobin, what will happen? Hemoglobin, it will be causing normocytic normochromic anemia. Normocytic normochromic anemia. Okay, how to remember? Whatever I am writing, just remember in that order. Okay, normocytic normochromic anemia. But whenever you see our CBC report, you first see the hemoglobin. So what will be there in case of KD? There will be normocytic normochromic anemia. Now hemoglobin, WBC. Next we see the WBC count, right? So there will be leukocytosis with neutrophilia, right? There will be leukocytosis with neutrophilia, and there. What about platelet? There will be thrombocytosis. Okay, thrombocytosis. What is the cutoff? We'll say in the latter half. Okay, thrombocytosis, we all know that is prominent in second week. Okay, prominent in second week. Okay, so that is CBC. Okay, now what about the other system? We can go for, what will you order? An LFT, right? An LFT, right? A liver function. So liver function test, what you can expect there? You will expect increased liver enzyme. Okay, increased liver enzyme or hepatitis. You can also get hepatomegaly there clinically. Okay, clinically hepatomegaly may be there. Okay, and liver enzymes will be high. Next, what you can get? Increased bilirubin. Okay, increased bilirubin, you will also get jaundice. That will translate into jaundice. Okay, and you will also get decreased albumin. Okay, you can get the edema in the limbs. Okay, so decreased albumin. That's about LFT. What about lipid profile? Anything in lipid profile? LFT will be followed by lipid profile, right? Anything in lipid profile? Yes, abnormal plasma lipids. How is it abnormal? Decrease in the HDL and increase in the triglycerides. That's how it's abnormal. Now, next thing, what you can order? You can see the electrolytes, right? Electrolytes, only abnormality most commonly found is hyponatremia. Okay, hyponatremia. That means decrease in the sodium. Okay. And what else can you order? Any renal function test? Yes, you can do urea creatinine, but usually it is normal. What we will do an urinary. What can we get? Sterile pyuria. We have already read it, right? Sterile pyuria. And the specimen should always be obtained by fresh, clean catch, voiding urine. Okay, not by catheterization. Okay, so sterile pyuria, right? Sterile pyuria more than 10 WBC per high power field. That's all we have already read. Okay, and what we can get in CSF, we already know that, increase in cell count, right? That we have already read. Okay, so if one thing you should remember, if CRP ESR is normal and platelet count is not increasing even at the end of 1 week, doubt the diagnosis. Doubt the diagnosis of KD. Okay, that you should remember always. That always you should remember. Okay, that is the key to diagnose KD. Now, what is not consistent with KD? What are the laboratory criteria that is not consistent with KD? That is not consistent. Yes, not consistent with KD. And another thing is not consistent with KD. If there is, in clinically, if there is exudative pharyngitis, you know that things. Exudative pharyngitis, okay. Or you can say if there is exudative conjunctivitis, we already said that, right? Conjunctivitis. If any vesicular rash is there, vesicular or bullous rash is there, or if there is any oral ulcer, okay, oral ulcer. Hepatomegaly is consistent with KD, but not splenomegaly. Splenomegaly is not consistent with KD. Cervical lymphadenopathy is consistent with KD, but generalized lymphadenopathy is not consistent with KD. Generalized lymphadenopathy is not consistent with KD. Okay, so what are the things that are not consistent? These are the not consistent clinical features, and this is the laboratory features. Okay, laboratory features. So this is lab and this is clinical features which are not consistent with KD. Not consistent. If these are present, you should doubt your diagnosis of Kawasaki. Okay, so that's it. Now already you have done almost all of the things, the laboratory criteria, laboratory investigation, we have done it. Now we should go in the first page, that what I have said. Yes, lab investigation. Lab investigation is over. Now we'll be coming to incomplete KD. That's a very interesting topic, very interesting, and especially for the postgraduates, it's very interesting, and you should know each and every bit of that. Okay, for you it is not the diagnosis of complete KD will be very obvious for you, but what about atypical KD? That's what the challenges come. Okay, so, and another thing you should remember, some infants, in some infants, very rarely, it's only for postgraduates, they can produce or they can present with DIC and thrombocytopenia, which is very rare. Thrombocytopenia, rare but possible in KD. Okay, that is possible. You should remember this. Okay. Look, now we'll be coming to atypical KD. Okay, what is atypical KD? It is which is not typical. Atypical KD. Atypical KD may be incomplete KD or node first KD. We'll see the node first KD, and then we'll go for incomplete KD. Okay, incomplete KD. What is node first KD? Only the lymph node, the cervical group, okay, will be involved first. Just like any viral fever. Okay, any viral fever. Latter rest of the signs develop. That's it. Okay. Now what is incomplete KD? Okay, what is incomplete KD? Incomplete KD is nothing but fever plus less than 4 of the 5 signs and symptoms. Okay. The criteria was fever plus 4 out of 5 of the signs. Okay. Now, if it is less than 4, means either maybe, fever plus 2 of the signs or 3 of the signs. So, you are doubtful about the diagnosis, right? So, what will you do? In that case, you will take help. In that case, take help of echo and lab investigation, what I have already read. Okay, That will be our motto in that case. Okay. How to do that? Okay. Suppose we'll just use your complete, the full of your strength, full of your cortical gray matters in this. You have to understand it's very, very, very clearly. Okay. Now what happens here? Fever. Suppose you have got a patient with fever for more than equals to 5 days plus any 2 or 3 criteria. Any 2 or 3 criteria for KD. For KD. Okay. So assess the patient characteristic first. What does that mean? I'm going to say that assess the patient characteristic. Okay. Patient characteristics. What do you mean by patient characteristics? Patient characteristics means the patient, are they consistent with KD? With KD, the clinical features at least. Lab, we do not know the lab till now, but as per the clinical features, is it consistent with KD or inconsistent with KD? What are the features that are inconsistent with KD? These are the features. Okay, these are the features which are inconsistent with KD. We have already said that. Okay, so some patient characteristics. So consistent KD, inconsistent. So you have said that yes, it is inconsistent with KD. So what will you do? So KD is unlikely there. KD unlikely. Now, if the features are consistent with KD, what will you do? Now you should take the help of laboratory test. Okay, then assess the laboratory test, lab test. Okay, what they are telling? They are telling either CRP, ESR are high or they are low. If they are low, then no doubt it is not, you cannot tell, say that it is KD yet. It may increase in due course, but it has not been increased. So if the CRP, is less than 3 milligram per DL and ESR less than 40 millimeter per hour, then it's not KD. You cannot say it KD. Okay, so you should assess, follow daily actually. Follow daily, monitor fever, and repeat test. Repeat test. Okay. So if it does not, now the CRP is more than 3. Okay, more than equals to 3 milligram per DL and or ESR. So you should look at this. This is and. So these two should be positive. Here any one can be positive. Either ESR is raised or CRP is raised. That's enough. Okay. So if it is positive, then we'll go for supplementary laboratory criteria. How many supplementary laboratory criteria are present? What are the supplementary laboratory criteria? We'll be coming to that. If less than 3 supplementary lab criteria is there, then we should take help of echo. Okay, take help of echocardiography. Okay, but if it is more than or equals to 3 supplemental lab criteria, if it is 3 or more, then no need to do an echo. Okay, you just start the treatment and do echo. Treat and echo. You should not wait for echo before starting the treatment. You should start the treatment and then you go for an echo. We already know that at the time of diagnosis, you should go for an echo and then you should repeat it 1 to 2 weeks after the onset of the disease, and then if it is normal, 6 to 8 weeks after that. So you know all those things. So treat and echo in case of 3 or more laboratory criteria. But if less than 3, then you should go for an echo first. Now, if the echo in that case comes positive, or negative. If it is positive, you should treat, obviously. If it is negative and fever subsides, then KD unlikely. So if fever subsides, not KD, but fever persists, you should take an expert opinion. Okay, in this case. And in case of CRP and ESR, both are less, you are monitoring that fever is coming or not. Okay, if fever continues for 2 more days, you should go again, you should test for that CRP, ESR. But if fever resolves, okay, then what should you do? You should look for peeling negative, peeling positive. Means subungual discommission is there, perineal discommission is there or not. If it is not there, no treatment. If it is there, you should go for echo. And as per the echo criteria, if it is positive, you treat. Negative, you do not have to treat, or you may take the expert opinion. So what is the criteria for echo to be positive? We already know. Okay, what are the criteria? Again, we have to see what are the criteria for echo positive. Yes, this is the criteria. Sorry. Yes. Regurgitation. So J score of LAD and RCA 2.5 or more according to AHA. Coronary arteries meet the criteria for aneurysm as per Japanese Ministry of Health. We know what is the criteria according to Japanese Ministry of Health. Just look my previous videos. We have already discussed it there elaborately. 3 or more suggestive features like perivascular brightness, lack of tapering, decreased LV function, mitral regurgitation. We have already said all those things. Okay, so that means that the echo is positive. Now echo is positive, you should treat. Now what are the supplemental lab criteria? There are 6 supplemental lab criteria. Okay, now what are the supplemental lab criteria that we have said? Now here supplemental lab criteria here. Now, what is that supplemental lab criteria? You should remember like this. From CBC 6 criteria are there. 6 criteria. From CBC there are 3. Means anemia for age. First thing, anemia for age. Next thing, WBC count. Yes, also there. WBC count more than 15,000 per microliter. Platelet count. We should expect thrombocytosis. So platelet more than 4.5 lakhs. Okay, per microliter. So 3 things from CBC, 2 things from LFT. Okay, 2 criteria from LFT. I am using another ink. Yes, LFT albumin is less than equals to 3 grams per DL, and next criteria is ALT is elevated more than 50 unit per liter. And the last criteria, the 6th criteria, is about urinary ME. So sterile pyuria more than equals to 10 WBC per high power field. So among the 6 criteria, these are the 6 criteria that is needed when you are doubtful about KD diagnosis. If any 3 of this is positive, 3 or more, you should go for treatment, and you should do an echo, obviously. If less than 3 supplemental criteria is present, take help of echo. If echo is positive, treat. Echo is negative, it may not be KD. Okay, so that is all that we have to need to know about incomplete KD. So diagnosing incomplete KD. So that is the flowchart. You should always remember this flowchart. Okay, that's the flowchart. You should always remember this.